All right, good morning, everyone. We're going to get started. For those of you that don't know me, I'm Helen Parsons. I'm one of the co-leaders of the Cancer Prevention and Control Program, which was formerly known as SPECS. And we are very excited, along with Dr. Ann Blaze, I'm excited to welcome Dr. Erin Hahn to join us for the seminar today. Dr. Hahn is a research scientist in the Division of Health Services Research and Implementation Science at Kaiser Permanente, Southern California. She is a health services researcher and implementation scientist with primary research interests in quality of care and oncology and the implementation of evidence-informed practices. And she currently is interested in post-treatment care of cancer survivors, leading several large studies of cancer prevention and cancer care delivery. And we're very excited to hear a little bit more about her work today. So welcome.
Hello, good morning. Thank you for coming, and thank you, Helen, and to Anne, who isn't here, but for the invitation. I think these in-person opportunities are really special, so I'm very happy to be here. And today I'm going to talk about a variety of different studies. Some are completed, some are just going on, some may never end, as you will see as things go. But as Dr. Parsons mentioned, I work in Kaiser Permanente, which is a really large healthcare system. It's a care delivery system. So it is a little different than being embedded in an academic center. I was previously at UCLA, part of that cancer center. So I've kind of had both experiences. And part of my role is being what we call an embedded researcher, meaning that I work very closely with clinical and operational leaders about what are their needs, where are they seeing where research might be able to intervene or improve or test an idea. So it's very collaborative. So it's not so much me coming up with an idea. As you'll see, none of my studies have new ideas. I would say zero. But that there are so many great ideas out there that have been tested that are not used and are not actually in our cancer centers or our community cancer practices. So we'll start off with a couple different implementation trials. And this first one is about screening for distress in medical oncology. So this is a very old idea at this point. It's been in our clinical care guidelines for well over a decade. And what's been difficult for programs, particularly community-based programs, places like Kaiser or non-academic centers, is to implement and sustain these kinds of programs. So this has been kind of a missing link, is saying sort of outside of an academic center, how do you create a program like this that will actually be used and be effective and sustained over time? And this has been something that's been included in like the Commission on Cancer, accreditations. And so there are some policy levers, as an implementation person, you always want to pay attention to that, but they don't apply everywhere, as you will see. And so this was a nice piece that was written by Paul Jacobson and Wynn Norton a while back that was just saying, kind of calling out, why aren't we using implementation science principles for some of these kinds of recommendations like distress screening? We should probably be really leaning on some of these frameworks and approaches to help us get the evidence into practice. And so one of the first, actually my personal principle for implementation science is it's the science of showing up. You really need to engage with whoever it is you're going to be working with. And so goal alignment is a kind of a nicer way to put that, where by going to meetings with our oncology chiefs, and this all started years ago, they wanted to do this, right? They felt like, hey, we should be doing this. Why aren't we doing this? And the reasons boiled down to what they always kind of boil down to, where they said, look, our patients are clearly distressed. These programs, there's a strong evidence base. We want to do it. But, the oncologists have no time. They really don't want to be involved. We don't want you to interrupt our clinical operations. All of the kind of administrative part of that was pretty challenging. So we had to say, okay, well, how do we come together and create a research question or a set of questions that will benefit this and get it off the ground and not be disruptive or, derail your oncologist's access time. And in the Kaiser environment, the Southern California where I am, the Commission on Cancer accreditation doesn't apply. They don't go for it. So we didn't have that policy lever to say, oh, well, we can check this box on the accreditation list. Like, oh, that doesn't matter to us. So we had to find kind of other parts of motivation there. And in these discussions, we came up with actually some sort of system leadership questions that went a bit beyond what my thinking was at the time. So one of their first questions was, look, we're a big integrated system. We already use the PHQ-9, the Patient Health Questionnaire, in primary care, right? Not for everybody, but it's there. And would a program like this even add benefit? Or would we just be double screening people that have already been screened? Right? And I was like, okay, this is an interesting question. I don't know, but let's see. Right? Let's see what we find out. And their other question was, well, if you had a program like this, would there be an impact on outpatient care utilization, like in oncology, in primary care, even in the ED? These are all big concerns from a systems perspective, where you may think, well, my little research program isn't going to do anything. But if you scale that out over 5 million members, it could have an impact. Right? So they wanted us to track a lot of this. So to me, this was a great opportunity to come up with a hybrid design. So an implementation science type design where you're looking both at the effectiveness still of your intervention. Are we actually identifying distressed patients? And all of the implementation kind of things we're interested in. How do we sustain it? What are the kind of barriers that are coming up? All of that. And I rely really heavily on the process. So hopefully this is familiar to most folks, but this is the Pragmatic Explanatory Continuum Indicator Summary tool. And this is a great tool for clinical trialists. And if you're designing a trial, this can kind of walk you through different elements of your trial. Say, well, how generalizable or maybe internally valid are the approaches I'm taking? And it's not to say that one is better than the other. If you're doing a very tightly controlled drug trial, you don't really care about generalizability at that point. But if you're way over on the other end of the continuum where we were, where we already had an evidence-based practice, right? We weren't coming up with a new way to do distress screening. We wanted to be as generalizable as we could. So for an example, the recruitment, again, back to our drug trial example, we put a lot of effort into recruiting, right? You are finding people, you are advertising, you are offering incentives, you're doing everything you can to get people interested. For a trial like ours, it was anybody who showed up in the clinic that had breast cancer. That was it, no other exclusions. So a very different kind of approach. And of course, we used some other beloved implementation tools, including the Consolidated Framework for Implementation Research, which is a wonderful big overarching framework that can help guide your data collection, and also the expert recommendations for implementing change, the ERIC. This is by Byron Powell and his group. And what I love about the ERIC is it actually boils down to basically a menu of implementation strategies. So it might be financial strategies, change management, policy, all different things. And they've organized it into these kind of columns. And I actually just print it out and bring it with me to meetings with leadership and say, okay, here's our research question. Are there things already happening in your clinic or in Kaiser at large that we can leverage as one of these strategies? So when I go away as a researcher, there's a way to sustain that. Okay? And so for this particular trial, things that where we're on the list and that were already happening within Kaiser are things like audit and feedback. Okay? That's very normal for health systems to provide performance data, right, back to their clinicians. Facilitation, also pretty normal within Kaiser. When there's a new initiative, we have a group that can help train and sustain new things. And then an adaptable workflow, which I'll talk about in a sec. Just to orient to Kaiser, the Southern California region it's a pretty big part of Kaiser. We have about almost 9,000 physicians and around 5 million members. And it stretches from kind of the middle of the state down to San Diego near the border with Mexico. And at the time of this trial, as I mentioned, we already had the PHQ. It was embedded into the workflows of the EMR, but it was so ad hoc in medical oncology, very little screening was actually happening. So we designed a pragmatic cluster randomized trial with 6 centers, and everybody got baseline education about distress screening. Hey, this is important. This is how you do it. Here's some tools, et cetera. And then at our intervention sites, we also plugged in those strategies around audit and feedback, facilitation, and helping them design a workflow. And we had hoped to recruit about 600 patients per arm. And the adaptable screening, this is really something that addresses generalizability. And in implementation science, there's a lot of focus right now on addressing local context. So how do you adapt an intervention in a way where you keep the core components, but recognize that clinic A or setting A is different than B, is different than C, right? Resources are different, leadership can be different, the patient population can be different, right? And so we have this kind of forms and functions idea. This is really drawing from Brian Mittman, who was one of my mentors at the time, where you say, okay, what are the core things that cannot be changed? And there will be some things. So for us, the screening had to be the PHQ-9. It couldn't be something else. It had to be scored the same way, right? They couldn't come up with some new way. The referral based on the scores had to be the same, right? The pathway. None of that could be altered. But what could be altered is, hey, could it be done on an iPad? Sure. Can it be pen and paper? Yes. Can a nurse do it? Absolutely. Can it be before the visit, after the visit? Yes. So we would help them figure it out. And again, this is different for those of you who participate in clinical trials. Usually there's a central protocol and that's it, right? You stick to it. For our intervention sites, we went to them and said, okay, what'll work for you? We'll document it for you, and then we'll create this facilitation guide. So that's why it is a little different. And then, as I mentioned, participant eligibility was just new diagnosis of breast cancer, no other exclusion at all. And they were offered screening as part of usual care. So we weren't consenting patients. And then the control sites, of course, had that education. So we actually exceeded our accrual target, which was great, over 1,400 folks. And very similar on demographic and kind of tumor characteristics. These are mostly early stage breast cancer. No surprise, really. And I'll just jump to our results. So we did a year-long intervention period, and over 80% of patients in our intervention sites were offered screening. So this was delightful. Now, what was a little shocking is that at our control sites, it was less than 1% of patients were offered screening. I mean, we knew there would be a difference, but we really didn't think it would be that dramatic. So we're like, wow, okay. And so of the folks who got screened at our intervention sites, we were tracking them to see what happened. So where did they score? About 10% were in the very highest need. About everybody received a referral. We did have some folks who said, no, thank you, I'll pass. And then of those who were referred, 3/4 of them completed at least one visit with behavioral health. And those were published in JAMA. And then we had those systems questions, right? Are we just double screening folks who are already screened somewhere else in our system? And largely no. So our control site, there were 9% of patients who had any other documented screening and 14% in our intervention site. So that question of, are we finding patients, who are kind of naive to screening was mostly yes, which is reassuring. And then we looked at those outpatient utilization outcomes. So these are adjusted rate ratios that we're looking at here for outpatient primary care, oncology, urgent care, and the ED. And so no significant difference between our groups on 3 of those 4. And in oncology, what was interesting, there was significantly less outpatient utilization in our intervention group. So this was a little bit of a surprise. And I wouldn't hang your hat on if you have a distress screening program, you'll magically have less utilization in your oncology program, but it was extremely reassuring to our clinical leaders to say, okay, this does not appear to increase utilization significantly. Like, we don't need a new staffing plan, for example, to scale a program like this. And then being, my embedded researcher implementation self, I was like, okay, well, the trial's done, but we're not done. We have to keep going, right? So what happens then? So we wanted to scale up and evaluate, really take all the tools that we had learned and apply it to all cancer types, no exclusions at all. So we had some internal funding as part of my position as an embedded researcher to do this, to develop a broadly applicable resource guide to help create those local workflows, do all of that. And then what that looks like is this. This is one of my favorite slides. Variation. So what we're looking at is each color is a different clinic. And the goal was the 80% line that we achieved in the trial. And then on the y-axis, we just have the proportion being screened. And so this starts, we actually have more tracking than this, but this is from the end of 2022 till the end of 2025. So we have this kind of initial run up where people were coming on board and kind of there was a lot of enthusiasm and great things. And then in 2025, you'll see there's some real declines. And what those map onto are actually labor strikes in our Kaiser region. So the screening is largely handled by the nurses and medical assistants. And so when they're on strike and we have traveling nurses and others who come in, it just doesn't get done in the same way. So now that's behind us. And so hopefully we'll see these rates go again. But we also track, we've created a large Tableau tracking sort of dashboard where we feed data back to the clinicians about who's getting screened, what kind of score do they have, what happened if they had a positive response to Q9, which is about potential for self-harm. And you see a lot of red on here because all this is tracking is a patient referred in the EPIC system based on their score. And so what this taught us was that very often a patient would have a high score and the oncology social worker would just come in the room. So there wasn't an actual referral created. They would just have a visit and then kind of move on, either make a plan of care or make a next visit, whatever it was. So we send these data out to the oncology nurse managers and they can kind of see, they take a look and they say, okay, well, I see we had some high scoring folks. Most of them already had a visit with their oncologist. So we kind of adjust this as we go. But it's a really helpful tool to just share with them. This is what your referral data looks like, which is easy for us to grab. So this project, as I said, is just kind of ongoing. I don't know if and when it will end, but we'll see. And this next one, so this is about improving HPV vaccination in children. So now we're moving out of medical oncology and into pediatrics. And this is a cluster randomized trial that I co-lead with one of my colleagues, Chun Chow. She is a cancer epidemiologist. And the idea here is no surprise to anyone in this room, but we have really strong recommendations for this particular vaccination, now starting as early as age 9 for both girls and boys. But when we look at any data set, whether it's across the US or at a certain health system or at a clinic level, generally speaking, it's pretty low. Typically about less than half of eligible children have actually completed the series. And there is data supporting that the earlier you get this particular vaccine, the more efficacious it is later in life. So this is something we really want to enthusiastically embrace. Most pediatricians just really want this to happen, but they meet a lot of resistance on a variety of levels. So building on this kind of implementation strategies idea, again, we didn't think, well, let's come up with a brand new intervention to improve HPV vaccination. There are a lot of them out there, and many of them have small but significant effects, right? Texting, letters, clinician education, all of these things. So we said, okay, we really don't need a new thing. We need a way to implement it and figure out what's the best way to do this. So for this is a 3-arm trial, and one arm has what we call the prescribed strategy. So this is very typical of how Kaiser and many other systems approach this, where they'll review the evidence, they'll sort of pick a bundle of things, and then everybody gets it the exact same way, right? Every clinic, it's just kind of rolled out. So we said, all right, that's our prescribed arm. Then we have a tailored arm. So this one is more resource intensive, where we go out to each of those clinics randomized to this arm, and we talk to them and say, what's your patient population like? What are your resources like? Of this list of interventions, what do you think you could successfully implement? And then does it need to be adapted in some way to suit what you've got? So a tougher lift, but potentially a greater payoff. Then we had a usual care arm for our 3rd arm where we did nothing. And the aims, our first aim was just looking at these kind of baseline associations of vaccine rates and what the clinicians thought that they were doing. So we did a big survey of clinicians, nurses, physicians, others, and said, well, how would you rate yourself, on these activities? And then we also sent one out to parents and guardians of vaccine eligible kids and asked them, well, how did this go? What did you, learn or remember, et cetera? And then we pulled a lot of data that I'll share a little bit of you. As I said, this one's ongoing, so I don't have all the final results to share. But our second aim is that the actual trial. So this is our 3-armed cluster RCT, and the primary outcome is the vaccine rate with a secondary outcome of this provider recommendation score, basically. And so with the tailoring, I'm just going to walk you through a little example of what this was like for us. So we would develop a local team, and this could be 2 or 3 people for a small clinic, or it could be a dozen people, for a larger clinic. And then we would actually share with them site-specific data from our surveys. So both for the parents and guardians and for the clinicians, and I'll show you that. And then we'd walk through that intervention selection and how they would like it delivered. Right? And so this is the index we used for the clinicians to kind of score themselves. And this is from Melissa Gilkey. She's over at UNC. Wonderful. She's one of our co-investigators. You see there's various domains that they kind of rate themselves on. How strongly do I talk about this? Is there a sense of urgency? Do I use a presumptive approach, right? Of course, we're doing this today. Let's move on, and all of that. And so this is the result from the whole survey. So we had just under 800 clinicians who responded. Higher score is kind of better. 6 would be the best. And you see most people gave themselves a 5, right? But we had some in this 0 to 4 range. And this is across 60 clinics. But rather than show that to our group of clinicians, because it's like, okay, whatever, that's our region, we would say, okay, for your office, so this is medical office number 6, we'd say, here's your clinic, here's the regional mean, here's what we're seeing, in the scores. And we would do this in person in a meeting, occasionally virtually, on Teams or something like that. And so they could ask us, well, what does this mean? Are we doing well? Are we doing poorly? Where do we need to improve? And we would share some other data that would also come from the survey about these are the kind of barriers your clinicians are reporting that they hear from parents and families. Right? Well, I just want to wait. They're not at risk. There's not a link to cancer, that kind of stuff. So this is the kind of information where they could say, okay, for our highest rated barriers, are there interventions that directly address that, more so than others? And then we had a couple other questions about the clinical team. Are they confident that they can improve rates? Do they have concerns about this particular vaccine? All of those kind of things. So all of this is very specific to their clinic. And then we would also share the parent survey results, right? So we kind of have the other side of the coin here, where we would randomly sample 100 parents or guardians of some that had a visit with a vaccine eligible child within the past month. And we would ask them, well, what do you remember? Did the doctor recommend it? Did the nurse? Did they say to get it today or that it could wait? And this particular clinic, same one, clinic 6, the nurses, 100% on everything. They were kicking it out of the park. And the doctors were like, well, some room for improvement, that we're hearing from the parents. And then they also had a parent kind of satisfaction with communication scale that we would score and share. And again, say, okay, here's the regional mean, here's where you all are, potentially some areas for improvement that these interventions could help address. So we would walk through all of that. This is our whole list of interventions. I'm not going to go through each one, so there's quite a few. But just as examples, they could opt into like text reminders to the parents, something like a second dose reminder. Very simple, can be quite effective, does not add work to the clinical team, pretty straightforward. Or things like this, these are booster videos. So we would have a group webinar, and then 2 weeks, 4 weeks, and 8 weeks later, we would share these booster videos that are designed for nursing huddles. Right, so they would be on an iPad. They're typically less than 2 minutes, and it would be one of our local doctors, this is Dr. Brownstein, talking about, reminding them about what we're doing and why. Right, so they could decide what they wanted to do. And, we're in our analysis phase right now. So I don't have those data to share. Sadly, we're a tiny bit behind schedule. But this has been a great project to kind of see how resource intensive is the tailoring and is it going to be worth it? And it might not be, right? There may be no difference from doing all of that compared to, the lesser intense strategy compared to doing nothing. So we shall see. All right, then we have some cancer care delivery studies. This first one, this is engaging primary care and cancer survivorship. And this was funded when Emily Tonorezos and Michelle Malika were in the Office of Cancer Survivorship. And no surprise to folks in this room, I'm sure, but the number of cancer survivors, particularly early stage, is just growing and growing. Right? This is not something that's going to go away. We're just going to continue to have advances in detection and treatment. And it's one of those good problems that we have is how do we now take care of these patients effectively? And so certainly at Kaiser and everywhere else, we have access issues in oncology, right? Clinics are very impacted. So we have the dual problem of a growing number of early stage cancer survivors who will live many, many years. And the more complex treatments now for advanced stage patients that take a lot more oncologist time or chair time or nurse time, right? So we kind of have a bundle of issues that are pressing in on oncology, and our oncologist workforce is not growing particularly quickly, and probably won't be for any time soon. And so there's been this growing interest in onco primary care. This is a collection of articles by lots of different folks, some of whom I get to work with, which is wonderful, but just trying to see how do we integrate primary care into the survivorship role. And there's a variety of models and programs across the US. Certainly there's advanced practice providers that take this on. There's the kind of traditional oncology model. There's a few primary care physicians out there that have been doing this for a long time, like Larissa Mikuledev and others. But it's still a pretty small portion of the pie with there's primary care involvement. And primary care physicians are pretty well positioned to take on some of these roles because survivorship is not just cancer surveillance, right? That's an important part of it, but it's also weight management and smoking cessation and a lot of general wellness tools that primary care docs and APPs, they're very well versed in this area. And so once again, this is not a new idea. Right? This is an idea that's been out there for a long time. Some of you may remember Ava Grenfell's work back in the 1990s. She did a trial, showing that GPs were basically equivalent to oncology specialists across a variety of outcomes. Right? So things like time to detection of recurrence, quality of life, mortality was in there, I think. So it's just been interesting that it's been a slow model to sort of take on. And is still pretty rare, at least in the US. And then observational studies, and when you look at systematic reviews and other things, patients who at least have an involved primary care tend to have higher overall quality of care scores, looking at different types of things. So we said, okay, let's conduct a prospective trial of early stage, low risk, I'll get to that in a second, breast and colorectal cancer patients. And we're going to transition them as early as 6 months after their treatment has ended. Right? So at least in the Kaiser system, for these patients, they have been staying with their oncologist for 5 or 10 years. I mean, a very long time. So this is a significant shift. And we had a group of primary care physicians that were actually trained and embedded into the oncology practice. They would have like a day a week clinic, the survivorship clinic. And we created a kind of composite outcome scores based on the NCCN and the USPSTF kind of age and gender recommendations based on their cancer type. And so we would look and say, create something called a prevention index mean, which I'll show you in a sec. We also did a large survey that we're still analyzing. We looked at non-recommended care because there was, again, a system leader concern of, well, will the primary care doctors all just start ordering PET scans and going crazy with imaging and all this sort of thing? I said, well, I don't think so, but we'll look, we'll take a look at that. And then we did also some qualitative work. And we had also some safety and monitoring outcomes. And actually your own Ann Blaze was part of my data safety monitoring board. And we looked at cancer-related hospitalizations, detection of metastatic or recurrent disease, and death. And we anticipated this would be pretty rare across this group, given the population. But what we wanted to make sure is that rates were basically comparable, right? That something didn't appear to be different in the primary care-led group. And this went through an interesting redesign. So we were awarded this funding, I think, in May of 2020. So COVID was absolutely dominating our health system. And so when I went back to our primary care leaders who had, agreed to be part of the trial and said, hey, great news. And several of them said, that's wonderful. And I cannot participate. If we're randomized to your intervention, I don't even have a minute of primary care time that I can give to this study. So we had to kind of go back to the drawing board. We did have 4 centers that said they could handle it, that they could take on the intervention. So we lost our randomization, but we switched to a quasi-experimental pre-post with control group design. And so analytically, we had to change some things around. We moved to a difference in differences type design. But we were just happy we were able to move forward at all because we were really worried that COVID would just undo the whole study. So we had a couple of key program elements that I like to highlight. And the first one is the physician survivorship training. So there are programs already out there, George Washington University, Stanford, that are online CME programs specifically for primary care doctors who are interested in or caring for survivors. So we said, okay, great, we'll start there and then see what we need. So we all went through this course together. We would meet once a month or once a week and have kind of a discussion, answer questions. Our regional chief of oncology would come with us to handle clinical queries. And then we said, okay, well, that was an intro. What else do you need? And this group of primary care doctors, they very specifically said, we need way more information on managing endocrine therapy. If I'm taking on a patient at 6 months, they may still be having side effects and dealing, and do I switch them? And, all of that. They wanted more information on unusual presentation of recurrence and also managing cancer pain and a couple other things. So we created kind of in-depth webinars with local experts to go through all of that, have a Q&A. Everything was recorded and provided to them for their education. So we had a lot of this group discussion, and all of this took about 5 months, I would say, this training part. And then we also wanted to create risk stratified pathways. We didn't want to just go to our oncologists and say, hey, please find us some low risk cancer patients that might want to do this program. That's rarely an effective recruitment strategy. So instead, we took it into our hands to create an algorithm based on sort of consensus-based eligibility requirement that I'll show in a minute, and just find them for the oncologists and send them, a note in the staff messaging part of the EHR and say, hey, this patient's probably eligible, let us know. And they would either say yes or no. If it was no, we would ask them why, so we could kind of keep track of that. But a very effective way to kind of get that oncology engagement and referral process going. And then the patient part was also really important because we'd, certainly been hearing for so many years that patients love their oncologist so much, they're never going to leave. So we had to really create some materials about the program, what it is, why are we doing it, who are these primary care doctors. We had bios and brochures. We put things on the patient portal, mailed them to their home. We had a talking point discussion with the oncologist so they could discuss it with their patient. So really three legs of the stool that were important for this program. And then the eligibility, we came up with an initial kind of inclusion criteria list within our research team, early stage disease, first primary cancer. They needed to have some curative intent treatment, years of diagnosis, had to have KP membership, et cetera. But then we went to our oncologists and said, who would you actually be comfortable referring, right, outside of that? And then to the primary care group and said, well, who would you be comfortable taking care of, right, actually receiving this as a patient? So then we had some additional criteria that popped up that we hadn't thought of, mostly around no neoadjuvant treatment at all. So that came through. I'm like, okay, nobody with neoadjuvant treatment is coming through. Ovarian suppression therapy, if it was ongoing, they wanted to stay with the oncologist. They could be eligible at the end of that potentially. And then any prior cancers, current enrollment in other trials, and then if they're undergoing any kind of workup. So that was actually a great process of engagement and figuring all this out. And then jumping to kind of the enrollment and acceptability of the program. So we had really high acceptability, which was so exciting because it was really a concern that the oncologist wouldn't refer anybody. And then if they did, that the patients wouldn't actually show up. And they'd say, you know what, I would prefer to stay with my oncologist because ultimately it's up to them. We couldn't force them to do one thing or another. So of our 773 patients that were eligible, 91% of them were referred. So they got that referral with the oncologist. And 75% of those completed their consultation in the survivorship clinic. And about 80% of them came back and had multiple visits with that survivorship center. So we're also tracking things like how many visits with the oncologist were happening and all of that. And then I'll just share, this is just the breast cancer cohort of this, but we were able to exceed our accrual, which was great. About 500 patients in the intervention group, about almost 10 times as many in our control group because we had so many more control centers. But again, very similar on most demographic and cancer characteristics, treatment. But I do like to highlight that there is a difference in race, ethnicity, and an insurance type. So the sites that we had that volunteered to be our intervention sites, 2 of them are in areas of Los Angeles that just have a very high proportion of Black residents. And so you can see that reflected in the race and ethnicity. It's different, right? And then also a higher proportion of patients with Medicaid at those 4 intervention sites compared to our other sites. So there are a few differences there. And then jumping to our quality of care results. So this gets back to the composite score I mentioned, where we took those recommendations from NCCN and USPSTF and basically assigned points, right? Did the patient get the thing? Then they get a point. And a prevention index mean is a way to measure over eligible time. So if it's supposed to happen annually, did it happen on the annual schedule? That kind of approach. And so as we had hypothesized, our intervention group with the primary care doctors, they have a higher overall prevention index mean compared to those who stayed in the oncology-led model. It is significant. I will say they're very close. And because this is Kaiser, there's already an emphasis on preventive medicine. So they're pretty high scores. But it was, kind of an achievement to say, hey, okay, look at this. The primary care docs can do cancer surveillance and stay on top of things like their diabetes screening, wellness exams, et cetera, for these cancer survivors. And so underneath the PI total, there's things that are broken out individually, like flu vaccine and annual breast cancer screening. And the denominators actually change for these because it depends, right? How old are they? Do they have remaining breast? That kind of thing. But the general trend holds where the intervention group have higher or as good scores. So again, a reassuring result, not surprising, but reassuring. And then we had those non-recommended services, right? The PET scans, the CTs, the tumor markers, none of which are recommended for asymptomatic early stage breast cancer patients. And the imaging pretty low for both PET and CT. CT actually significantly lower in our primary care group, but where there's really a difference is those tumor marker tests. Where the primary care group, barely any, where our oncology group, about 20%. So a big difference there, which has actually caught the eye of our oncology leadership, who's now kind of looking into, well, why are we doing so many of these tumor marker tests for these patients? And then we looked at those 3 safety things around inpatient cancer-related hospitalization, deaths, and recurrence or metastatic disease. No significant difference between the group and overall quite low as we had hypothesized. And so these are all being written up into manuscripts. We'll have an algorithm, we'll have some qualitative results, we've got surveys, and then we've got our main findings here, which I presented at the ASCO Quality Symposium last year. So it's moving along. I was talking last night, writing manuscripts. It's a lengthy process sometimes. And then this final project that we're working on, this is focused on adolescent and young adult cancer survivors, our AYA group. And this is a PO1 that actually has 5 PIs, so I'm one of 5. It's funded through the NCI. And each project has a different focus. So one is on fertility, that's led by Hazel Nichols over at UNC. The one I lead is on patterns of care and care transitions in those kind of what I call early survivorship years. So about 2 to 5 years after their diagnosis, what's going on. And then we have a late effects project that's led by Teresa Keegan over at UC Davis. And we also have our cores. So there's an admin core, a biostatistical core, and a survey core. And just to show kind of our participating institutions, we have amazing collaborators over this project. It's become very large and has a lot of supplements and other, offshoot work that we've been able to do. But just a lovely kind of group and productive group as well, as you'll see. And so we wrote these projects to kind of focus on different parts of the care continuum, with fertility really around the timing of diagnosis and those initial treatments. My project on that early phase of survivorship, and then late effects really spanning quite a number of years from diagnosis on. And so I'll share a little data from 2 different projects from the one that I lead on this patterns of care idea. And our first very fundamental question was, what does contact look like for the healthcare system for these younger patients? Right? So AYAs, the common definition is 15 to 39 at the time of diagnosis. And these are patients who traditionally have a lot of mobility in their lives, right? They're starting school, they're ending school, they're starting a family, they have new jobs, different jobs. And within our country, that's very often those transitions are tied to changes in your health insurance, right? And that can be incredibly disruptive. You might not be able to see the oncologist you've been seeing because they're no longer a network, right? Or you've moved, or different things come up. And so historically, this has been a tough group to track and to get good data on, and to kind of see, are they getting the type of care that they need and that is recommended for them during survivorship. So one of our very first projects, just kind of as we were getting out the door, was just looking at, for Kaiser data, what does this look like? Are these patients coming in? Let's just get our arms around that type of question. And so these are patients who were diagnosed with the 10 most common AYA cancers, so it's a little different than pediatrics or older adults, but you'll see the list there. And we started capturing all primary care and oncology-related care visits. And because the integrated system, we have a pretty high degree of certainty of these are the visits that are actually happening. And we do receive outside claims. So if someone is getting care somewhere else, it does get sucked into our data system. So we can count that as well. But for outpatient care, that's really rare for that to happen. And so we wanted to cast a wide net as possible. So for oncology, we had obviously medical oncology, rad-onc surgery, but then depending on the kind of cancer the patient had, we would also include other specialty care. So if they had thyroid cancer, did they see an endocrinologist, right? That would sort of check the box if they had a survivorship visit potentially. If they had a GI cancer, did they see a gastroenterologist, that type of thing. So it was a pretty big net. And we just started categorizing patients. Did they have no visits in a given year of their surveillance? Again, this is that 2 to 5 period. Did they have 1? Did they have 2? Did they have 3, et cetera? And so this is a group of about 8,000 patients, lots of different cancer types, as we talked about. And mostly what I want to highlight here is the insurance type. So even within a system like Kaiser Permanente, there are different types of insurance products. So there can be a high deductible product, for example, which is typically defined as an out-of-pocket deductible of $1,500 to $2,000 per year, and it can be much higher. We also have Medicaid, Medicare, government type insurances. And so as a health services person, this is always very important to me to throw that in, right? What's going on with that when we start looking at our models. So here's just a graph of some of those outpatient results. And anything oncology related is in blue, and anything primary care related is in green. And so you can see there's kind of a similar breakdown where we had about a third of patients in both categories that had quite a few visits, 3 or more. But we also had a big group down at the bottom that didn't have any. And again, remember, these are folks that definitely have insurance and are alive at the time of that year when we were looking at them. And the cohort itself shrinks over time as people's insurance change and a few pass away. But the 0 visit group, particularly in oncology, gets bigger over time. Like, well, this is a little concerning. These are patients that have had cancer. We tried to cast this wide net to catch everything, and we still have all these patients with no visits. Like, what's going on here? So my initial thought was, well, maybe everybody in that 0 visit group in the first year, maybe they all flow into having a visit in a subsequent year, right? That seems likely. We're just kind of putting this year boundary on them. Maybe if we take that away, we might be able to see something else. So this is one way to visualize transitions. This is a Sankey diagram. They're a little funky to interpret, so you'll have to stay with me here. But basically, the columns here are year 2, year 3, and year 4 after diagnosis. And that mint green group that's down in the bottom corner, that's everybody who started off with 0 oncology visit in the first year. So what I had hoped to see is that entire mint green line would flow into a blue or a purple, meaning, oh, they had a visit in the next year. But that's not what happened. So almost half of them do not come out of that 0 visit group. They just stay in it. So this is concerning when you start to think these are patients who have had cancer. Even if it was a relatively simple, surgery only treatment, there should be something happening. So we did a little modeling just to see, well, who's in this group? And this really took a big picture view of they had no visit at all with oncology through that whole period. And folks who were more likely to be in the 0 visit group over the whole period were men and non-Hispanic Black compared to non-Hispanic white patients. That high deductible came in. They had a high deductible plan compared to sort of a typical commercial plan. They were way more likely to have 0 visits. And then the Medicaid insurance, also more likely to have 0 visits. And so my colleague, Karen Wordenley, who works with me on this project, she took this same cohort of about these 8,000 folks, and she actually looked at the flip of this. She looked at the emergency department. Said, well, are they getting care in the emergency department? Like, what's happening here? And ED visits were pretty rare overall. When you look, you can see, lots of zeros here. But when you start to look at the 95th and the 98th and the 99th percentile, we have patients that had a lot of ED visits. And the primary diagnosis for most of these was pain, which can be pretty scary when you've had cancer, right? When you're not quite sure, what does this mean, right? Do I have a headache or do I have a metastatic brain, right? And so when she started looking at stratifying by things like race and ethnicity, we could see there was a difference with non-Hispanic Black patients more likely to have ED visits. They had more ED visits per 1,000 person years. And so all of this to me points to a system problem, right? There's some access issues going on here that we as a healthcare system are not doing a good job serving some of these patients potentially. And so I have a new UG3 study that's funded through the NCI that is to create an AYA specific navigation program. And this is just getting off the ground. We just got funded in October, but we're excited to do this. And it just seems like there's such a need in this population. So we're happy to use some of that data from the PO1 to hopefully take these next steps. These are just a few papers that have come out of the PO1. There's a lot, but some of them have just been so impactful, particularly around the late effects. And because for this group, it is different, right? They're not pediatrics where we have all that great data from CCSS and others. So it's been really important to us to start looking at this group in particular. And then I just take a minute to thank an incredible and long list of collaborators, advisors, other folks. This is my KP research team that works with me on almost all of my studies. And also just to thank you and to thank you for being here, and also just a thank you to showing us all what democracy looks like here in this state. It has been pretty heartening, I have to say. So thank you from California for that. And that's it.
I have microphones for anyone who has a question. Please raise your hand.
That was really cool. Thank you for a very educational and entertaining presentation. I have a question in where you showed the difference between the primary care folks and the oncologists in sending marker tests.
Oh.
Do you think that this might, as we get better at developing tests that are sensitive in identifying minimal residual disease or recurrence, do you think that that's going to sort of mirror what you're seeing, that the oncologist might be more informed, more anxious, more willing to run those tests, whether or not they're already covered by insurance, than the primary care folks? And might that translate into difference in outcomes for that small part of the population that would actually be detected and potentially intervened?
That's an interesting question. And I'll start with the oncologist part. So a few years back, I actually did a study where we looked at use of this particular set of non-recommended tumor markers. And we could see in our region, and also we worked with Intermountain Healthcare and some other parts of Kaiser, that we had just high use of these tests in these early stage breast cancer survivors. So we went out and interviewed oncologists about this, and we knew if they were a high or a low user. So we could kind of assign, say, okay, high users are telling us this, low users are telling us this. And the high users felt very strongly that these tests helped manage their patients' anxiety. So they were well aware that this isn't actually providing a lot of clinical benefit in terms of detecting recurrence early. But it's helping my patient feel like they're doing everything they can. And so that, I think, drives a lot of clinician behavior where they're well aware of the guideline and they may agree with it. But it can be difficult to say no to patients, even if something is potentially not clinically indicated when the perceived harms are low. Now, there are actually harms with over-testing and overuse of these things. It can actually create more anxiety. The blood draw is relatively small in intervention, but can be a problem. And then there's costs. Now, as we move along with tests becoming better, right? This set of tests is not particularly good. So that's why we're not supposed to be using them. But if they become better, what is better, right? Is the benefit enough to justify use? And I think we would see the exact same pattern where primary care doctors wouldn't use them as much as oncologists, because the oncologists' training and experience, they never want to miss a cancer ever, right? And understandably so. So I think that pattern will continue, for sure.
I had a question about your HPV vaccine study. So I think you said data collection is complete. So was it completed before last year and the changes? So I guess I'm curious what you think your results will mean in this new era of vaccine hesitancy.
Yeah, and one of the things we actually added on to help us look at that is we had done the parent guardian surveys were done at 3 different time points. And it's different groups of parents because we were randomly choosing when they had an eligible visit with a child. But the norms and perceived value of vaccines is undergoing changes, right? And so we hadn't planned to look at this, but we're now looking at because there's a whole attitude scale that I don't think I shared, but we're looking at baseline and then time point 1, which was about 1.5 years later, and then time point 2, which was pretty recent. So we're going to see, did that appear to change? And then did our vaccine, actual results change? And because we have a usual care arm, we can, just see, independent of anything that we did things take a turn? And I don't know yet, but we definitely are building that in now in a way that we hadn't planned to. Yeah. So hopefully people are still getting their vaccines. We'll see.
All right, are there any other questions?
Yeah.
Oh, can you just take that mic right there?
Thanks.
Great. Hi. I was wondering, in the survivorship with the PCPs, I was wondering in the control group whether patients were seeing like both an oncologist and a primary care, or were they seeing oncology only, and was like a goal of the work to have people who weren't seeing primary care now see primary care, or whether it was like to decrease like unnecessary load on the oncology so they could see more new patients.
Yeah, it was more the latter. And we did track all of that. And so in the Kaiser system, everyone has an assigned primary care doctor. Whether or not you see that doctor is up to you, but you have somebody. And so part of the design of the study, that was one of those systems level questions, is they said, well, if we're putting this primary care doctor into this role, do we then take that patient out of their assigned person and sort of give it to this other person? And that turned out to be incredibly complicated. So we didn't do that. And so anybody could see they could see the survivorship PCP if they were in the intervention arm. They could see their regular PCP. They could even see their oncologist. They weren't prevented from doing that. And then in the oncology arm, they had their assigned doctor, they had their oncologist. So the best we could kind of come up with is, well, let's just track everything over time. Like, how many visits are there? And what we had hoped was that in the primary care survivorship clinic, that their primary care assigned utilization would go down, and they would also rarely see oncology, so that this survivorship PCP would be sort of a replacement, kind of a quasi replacement. And we did see that. The oncology visits went way down, almost 0. And then the primary care, the assigned primary care doctors still had utilization, but it's slightly less. So, because what we didn't want to have is that, oh, now everybody's seeing 3 doctors, right? that would not be ideal. So it doesn't seem like that's happening. Yeah, good question.
All right. I don't see any more hands up, so let's say thank you one more time for a great seminar.
Thank you.